So what we saw was essentially that for the primary endpoint, which is modified progression-free survival, that's normal progression-free survival, so time to progression, to death from any cause, but also to any insufficient response to therapy at the end, leading to subsequent anti-cancer therapy, being it systemic or radiotherapy. So for that primary endpoint, there was no statistically significant difference between the experimental and the standard arm, neither in stage 3 nor in patients with nodal disease. But in the high-risk groups, stage 4, and patients with one or more sites of extranodal disease, there was a difference which, as you could expect, is larger than in the total ITT population. So the magnitude is around 7%, and the hazard ratio around 0.70. And what does that mean? That means roughly a 30% reduction in the risk of an MPFS event in the observation period. So that's a reduction in the risk of failing frontline therapy with approximately 30% in a smaller group of patients. Also, today's presentation gave some results showing a benefit in terms of overall survival, which is of course always a very interesting clinical endpoint for the clinician audience. The difference at 2 years, roughly 4% in these high-risk subgroups. It doesn't sound like a lot, but as you probably know, Hodgkin lymphoma, even advanced stage, is a disease where the vast majority of patients are cured. So overall survival differences in studies are indeed rare.